for everyone. So we are still experiencing sometimes technical difficulties, but we will go over this like during the time. So I'm not concerned about this. So this is an exciting opportunity for those who are not a medical kidney pathologist, or I will say non-kidney pathologist, to see how our colleagues in the medical kidney world are actually handling the renal allografts. This is going to be an update for me, and I'm sure for some of you who haven't seen those or who have not been exposed enough during your training or during your practice. So with this, I would like to give the rest of the introduction to Carmen. She can update us on the wonderful speakers as well as additional in-house related issues.
Thank you very, very much for joining us. I want to thank our starting team today, especially Navida, Rehab, Shifa. They volunteer nicely, kindly to start with this experiment that is going to be our new rounds, that are virtual rounds, because as we are learning from them, so I really appreciate your tolerance for things that are not perfect, but you can be sure we worked the last 2 weeks, Navida, Rehab, Shifa, trying to bring you the best. So the goal of this special, this case-based rounds today is that all the pathologists that are not aware how we handle transplants. Of course, when you move to a place, to different places, are you going to see more pathology or general pathology? Probably you have to deal with transplants. And they are always important because you have to do crucial decisions how to treat. So that's why we decided to take this approach. So you will be able how to manage these transplants. I welcome everyone. I remind you that all fellows, please, my office is always open for all of you, wherever you need, as Oscar, as me, Anna Marie, that we are the leadership in education. Everything you need, don't wait until the end of your fellowship or until the end of something or when something worse happens. Just communicate us. I'm always available for you. Okay, so thank you very much, Shifa. Thank you very much, Rehab. Of course, you will have you go to yours. So, you know, the government has canceled the Halloween, so you will not be able to pick up house to house, but we brought some treats for you. I was able to order some, so you will get one after the conference. Navida will give you some of them. So thank you very much, and please just start, Shifa.
So Shifa, it's your turn. So we are leaving the platform to you, and then after Rehab.
Okay, thank you so much.
Thank you.
Hi, my name is
Sure,
Shifa.
no problem.
Okay. My name is Shifa. I'm a second year, almost finished second year renal pathology fellowship. I present today a case along with my colleague Rehab Fatani. I'll start with the case 1. But before I start, I just reminder for the fellows and residents, there's attendance sheet at the last 5 minutes of the meeting. You can send your name in the chat, so don't forget this. Our cases today will be about the two renal allografts to be discussed in the and the objective will be how the renal pathology allograft should be approached and the more frequent pathologies affecting the kidney. So case number 1, a 60 years old Hispanic gentleman underwent living donor kidney transplant for diabetic end-stage renal disease. And 11 months after the transplant, he presented to the emergency department complaining of fever along with constitutional symptoms, including myalgia, fatigue, and diffuse macular rash over the back and abdomen. So the patient was admitted to the hospital to do some investigations, and I put some relevant laboratory information for this patient. His creatinine was elevated to 3.1 milligram per deciliter, as well as the urine analysis showed increased protein or proteinuria, hematuria, WBC cast, and hemigranular cast. Other investigations, including the glomerulonephritis workup like ANA, ANCA, and others like C3, C4, all were negative. So as a summary, this patient has febrile illness with skin rash and acute renal failure, and he did a renal allograft almost 1 year ago. So what's your differential diagnosis in this case? So as a renal pathologist, when I handling any renal allograft, I have to think about some common pathologies affecting the renal allograft. First of all, I have to rule out rejection, and I have to rule out recurrent disease, in addition to looking for acute tubular necrosis or acute tubular injury, CNI toxicity, any obstruction or infection. Regarding the rejection, whatever the clinical presentation, acute cellular or antibody-mediated rejection must be the first possibility for any renal allograft. Even this patient has febrile illness with acute renal failure, we have to put this possibility in consideration. Although the fever with acute rejection nowadays is uncommon due to modern immunosuppression therapy that are used nowadays, but still a possibility. Other thing we have to think about it, the acute tubular necrosis or acute tubular injury that can be for different causes, including pre-renal causes, renal causes, and post-renal causes. And in most times, the acute tubular necrosis is secondary to ischemic or nephrotoxin injury to the kidney. And in many times, acute tubular injury can be associated pathologic changes in other pathologies. So this patient most probably, or I can say 100% he has acute tubular injury or necrosis, but I have to figure out what is the cause of acute tubular injury in this patient. Also, we have to consider the CNI toxicity. The two most common CNI that use a renal allograft nowadays are cyclosporin A and tacrolimus. This patient was taking tacrolimus as treatment as immunosuppression therapy for his renal allograft, in addition to MMF and prednisone. And for the MMF and prednisone are usually not associated with nephrotoxicity, but CNI, including the tacrolimus, usually cause toxicity that can be acute or chronic. But in this patient, I don't think he has CNI toxicity because the tacrolimus level was within normal limits. Also, I have to consider the recurrent disease in this patient. This patient was transplanted due to end-stage renal disease secondary to diabetic nephropathy. When we come back to the history, the patient has proteinuria, but the amount of proteinuria is not to the level that's seen in the diabetic patient. And recurrent disease as diabetic nephropathy can't explain the presence of fever and skin rash with acute renal failure. Also, we have to consider the obstruction in any renal allograft. The obstruction can be caused by, most commonly by hematoma in the subcapsular area of the kidney. And in this patient, after 11 months, we think about a trauma or history of recent kidney biopsy that causing obstruction. But this patient doesn't have any history of trauma or recent kidney biopsy, as well as the renal ultrasound was normal. And finally, we have to consider renal infections in this patient because for sure he has fever and febrile illness with acute renal failure. And as we know, acute pyelonephritis is not uncommon in the renal allograft. So we have to put it in our differential diagnosis. So I'll show you the kidney biopsy. The kidney biopsy was taken in the view of active urine sediment, skin rash, and graft dysfunction to figure out the cause of patient's symptoms. So we have the first image here showing renal medulla or corticomedullary junction. As we see here, we can see the glomeruli and we can see the medullary arrays in these areas. So we have medullary tissue. And as you see here, we have these round areas here and there. We can show you these rounded areas of inflammation. And we consider these aggregates of histocyte with lymphocytes in these areas as vague or small granulomas affecting the medullary area of the kidney. We have also small areas of interstitial hemorrhage here and there. And we have also areas of inflammation by lymphocytes. Maybe this is a BS stained sections showing a better view of these small granulomas. As you see, the granulomas are tubulocentric, which means that these granulomas around the tubules. So we have here the tubular basement membranes, and we have these granulomas destructing the tubules. Along with these granulomas, we have tubular destruction, as we see here, severe tubulitis with destruction of the of this tubule. Of course, the inflammation composed of lymphocytes and plasma cells. Also, we have small areas of necrosis in the tubules, but not in the granuloma itself here, like this area. Also, we have other areas of inflammation showing tubulitis. As we see here, these lymphocytes inside the epithelial cells of the tubules, we call it tubulitis. And in this area, it is mild tubulitis. And we have seen the lymphocytes, plasma cells, very few eosinophils. Again, there's granulomas in the interstitium, and very obviously there's foci of interstitial hemorrhage. Other core of kidney showing cortex with almost unremarkable changes. We can't see any inflammation. The glomeruli completely unremarkable. There's no evidence of recurrent disease in this patient. We don't have mesangial expansion, endo or extracapillary hypercellularity, and completely unremarkable. And it's good to focus on this slide, because in the renal allograft, the pathology can be very focal. So the radiologist has to take multiple fragments or multiple cores from the renal cortex and medulla to figure out what is going on in the kidney. Otherwise, we will miss the pathology, as we see here. In this core, it's completely unremarkable. So, Rehab, could you please share the pulse? Hello, Rehab. Okay. So, according to the findings that I presented, as a summary, we have a middle-aged male patient with renal allograft 1 year ago with febrile illness with skin rash and acute renal failure. The biopsy showing vague granulomatous reaction with foci of interstitial hemorrhage and tubular necrosis. What is the most likely diagnosis in this case?
For how long should we wait for voting?
1 minute is enough, I think. Okay, some people say sarcoidosis, others think about drug reaction, others think about infection. Okay.
So I'll end it.
Yeah, we can end it. Thank you so much. So 53 of the participants thinking that the changes are granulomatous reaction, drug-induced, and 41 thinking that it is granulomatous interstitial nephritis due to infection, 1 person thinking about sarcoidosis. Okay. I'll show you the diagnosis at the end, but we have to discuss these differential diagnoses with each other. So in the kidney, we have granulomatous interstitial nephritis. In renal allograft, the differential diagnosis, it will be as any renal biopsy, including any disease that causes granulomatous reaction in the kidney. including infections, sarcoidosis, drug-induced ANCA-type vasculitis. And we can start with the drug-induced, as most of you thinking that this is a drug-induced granulomatous reaction. I don't think this is drug-induced because the granuloma that we seen, it was like small granulomas with inflammation. But the clinical history, the patient has a fever. So drug-induced granulomatous reaction can't explain the presence of fever in this patient. Or the patient has skin rash that can be a be a reaction to a drug like hypersensitivity reaction, but the fever can't be explained by the drugs. The second option, 41% of the participants thinking that this is infection, which I think also this most likely could be infections because there is inflammation and the inflammation composed of lymphocyte and plasma cells in the kidney. We have to think about infections in addition to presence of these big granulomas with areas of necrosis in the tubules and interstitial hemorrhage make me think about infection. According to the sarcoidosis, it's very far because in the sarcoidosis, the granulomas tend to be well-formed, discrete with many giant cells. So this is not the case. And ANCA vasculitis, it is not ANCA vasculitis because in ANCA vasculitis, we have to see crescentic lesion, active or chronic. But in this case, we don't have the crescentic lesions. And in many times, we can see these granulomas as a foreign body type granulomatous reaction due to non-specific tubular rupture or due to calcium or oxalate deposition in the kidney, and it was not our case. And if no cause of the granulomatous inflammation in the kidney is found, so we can call it idiopathic granulomatous tubular interstitial nephritis. So, as the further investigations, we did, as from the beginning, we're thinking that this is granulomatous tubular interstitial nephritis induced by infection. We have to think about the most common infections that could affect the kidney. For the infections in general that cause granulomatous reaction, we have bacterial infections, viral infections, and fungal infections. The most common bacterial infection, as we know, it is TB or Mycobacterium TB, and our case didn't show any caseation or caseating granulomas. So I have to think mostly about viral infection in this case. So I did a panel of immunohistochemistry for the most common viral infection affecting the kidney. So we did immunohistochemistry for polyomavirus, which is already, we did it as a routine stain in every allograft kidney biopsy. We did also adenovirus immunohistochemistry. We didn't do CMV immunohistochemistry because we didn't find these large intranuclear and small cytoplasmic basophilic inclusions that typically seen in CMV. So we did, as a first panel, adenovirus immunohistochemistry and polyomavirus immunohistochemistry. So as a result, polyomavirus immunohistochemistry came up negative, adenovirus immunohistochemistry came up positive. So this is immunohistochemistry for adenovirus, positive in the severely destructed tubule in our case. So we have the nuclear staining in these areas. So we did electron microscope to further confirm our diagnosis or our finding of immunohistochemistry positivity for adenovirus. This is this image for ultrastructural examination from our case. As we see here, first, as initial view, there's just segmental podocyte effacement. We don't have any electron density in the glomerular basement membrane or in the mesangium. And so we exclude the podocytopathy and immune complex mediated glomerulonephritis that can be captured by electron microscope. We did some images from, also we have this tubular reticular inclusions, or we can abbreviate it as TRIs. These are structures usually seen in the endothelial cells and sometimes in the epithelial cells in the autoimmune diseases and viral infections and in patients taking interferon treatment. So as we identify these structures, we think about autoimmune disease or viral infection, but in our case, it's further support our thinking about viral infection in this case. So let's go to the areas of the immunohistochemistry positivity for adenovirus, I mean to the tubular epithelial cells. We take some images and we found these small spherules or small particles. So when we found any deposits or any particles in the electron microscope, we have to take some measurements for these particles. In this case, we find the average diameter of these crystalline arrays of viral particles from 75 nanometer to 80 nanometer. And these particles are characteristic for adenovirus infection. So our diagnosis was adenovirus-induced granulomatous tubular interstitial nephritis with focal tubular necrosis. As a confirmation to our diagnosis, the PCR for adenovirus and other viruses is done, and it came up positive for adenovirus and negative for CMV, polyomavirus, parvovirus, and other viruses. This patient was treated symptomatically with decreased the amount of immunosuppression, so MMF was stopped, and the patient showed good improvement with the resolution of symptoms just a few days after decreased amount of immunosuppression, and the creatinine stabilized at 1.7 milligram per deciliter. And after 6 weeks, the serum PCR was done for adenovirus and showed negative result. So we can go to the discussion about the adenovirus infection. Adenovirus, it was first described in 1953 as an adenoid degenerating agent because it was isolated from human adenoid tissue and showed cytopathogenic changes in the tissue culture. And subsequently, it is found to be a DNA virus related to mastadenovirus. So, as we know, the adenovirus is a common cause of upper and lower respiratory tract infection. It's also a common cause of conjunctivitis, gastroenteritis, and usually these infections are self-limited in immunocompetent patients, but can cause serious infections in neonates and immunocompromised patients. So adenovirus infection can be encountered or seen in renal allografts, and usually it came up, or the clinical manifestation usually as a hemorrhagic cystitis, and in very rare cases it can be renal involvement with granulomatous tubular interstitial nephritis. So in this survey, it was conducted on solid organ transplant. The incidence of adenovirus viremia as demonstrated in this surveillance study, included 263 solid organ transplant recipients from about 57 centers, was 7%, with the highest in this incidence was in the liver transplant patients with 8%, followed by hearts 6.7% and kidney 6.5%. Regarding the adenovirus infection in patients in general, it usually causes upper respiratory tract infections with maculopapular skin rash. But in our case, it was really interesting because when we reviewed the lecturer, the granulomatous tubular interstitial nephritis caused by adenovirus usually came with a renal-related manifestation, including renal allograft dysfunction with increasing creatinine, decreased GFR, gross hematuria, dysuria, pain at the site of transplant in kidney, renal mass. But I didn't find any patient with granulomatous tubular interstitial nephritis with skin rash. So we have to consider skin rash with tubular interstitial nephritis, in any differential diagnosis in renal allograft to rule out viral infection or other types of infections. So as a summary, we have just make a summary for the 3 most common viruses that can cause infection to allograft kidney, including adenovirus, CMV, and polyomavirus. Regarding the adenovirus, the most important clue for diagnosis of adenovirus is the presence of big or small granulomatous reaction with severely destructed tubules, areas of parenchymal necrosis, smudgy type viral inclusions, and very importantly, the presence of interstitial hemorrhage. And these characteristic crystalline arrays of viral particles with a diameter between 75 to 80 nanometer is all of these are clue for adenovirus and must be confirmed by immunohistochemistry or PCR for adenovirus. Regarding the polyomavirus, which is the most commonly viral infection encountered in the renal allograft, as we do the immunohistochemical staining for this virus for every renal allograft biopsy, the polyomavirus usually characterized by zonal inflammation in the kidney with the homogeneous ground glass appearance of nuclear inclusions inside the tubular epithelium and the small viral particles by EM. These particle diameter ranging from 30 to 50 nanometer in diameter. And finally, we have the CMV infection. Again, it causes interstitial inflammation with tubulitis and interstitial inflammation, but the characteristic finding in CMV nephritis is the presence of homogeneous viral inclusion with a halo inside the tubular epithelium nuclei and the small basophilic viral inclusions inside the cytoplasm and the characteristic large viral particles in the ultrastructural examination with diameter about 150 nanometer. And just in our case, just to come back to our case, somebody will say why this patient doesn't have a renal allograft rejection. We see the tubular interstitial inflammation. But it's very important to rule out also rejection in this case. But in our case, the interstitial inflammation in the cortical area was less than 10% of the whole cortical tissue submitted in this patient. And we didn't find other manifestation or other pathologic features of rejection like endarteritis, glomerulitis, PTCitis, C4D was negative, DSA was negative. The areas devoid of viral smudgy nuclei or viral inclusions was showing very minimal inflammation. So the rejection in this case was excluded. And also as a confirmation to our diagnosis, the patient was improved by decreased amount of immunosuppression. So as a conclusion, this case highlights the need of considering adenovirus infection in any renal allograft recipient presented with febrile illness, with skin rash and granulomatous interstitial nephritis. And we have to consider adenovirus infection in considering the adenovirus infection requires high index of clinical suspicion, in addition to clinical pathological correlation and use of multiple diagnostic modalities like PCR, tissue biopsy with immunohistochemistry, ultrastructural examination, and that's it. Thank you for your attendance. And any question?
Shifa, I suggested we only get burning questions at this time. So if there's no burning questions, maybe we can accept all relevant questions after Rehab's presentations in the interest of time.
Okay.
But if there are any few burning questions or comments, we can have 1 or 2 minutes at this time.
And also send it to the chat.
Yes, that's a good idea. Yes, Carmen, thank you.
Thank you so much.
If there are no questions, I don't see any chat going on as well, but I suggest we move with the next case. And thank you very much, Shifa, for your wonderful presentation. It was so good. Thank you.
Thank you.
Hello, everyone. Thank you very much for joining today to our case-based round. My name is Rihab Fatani. Rihab from your throat. You pronounce it Rihab. It's a common Arabic name. So because my parents were Arabic teachers, so they don't know that Rihab in English does mean another thing. So if I was choosing my English name, I will put I instead of E. So you can know that it's a different meaning. All right. Our next case about I don't know how to turn the slide. Okay, I'm trying to use the spotlight. It doesn't. Sorry, bear with me. I don't know what happened. So anyhow, I will share from the other computer. Our patient was a 35-year-old female who underwent a transplant, kidney transplant in 2015. Why? Because she had a renal failure because of lupus nephritis. And do you hear me? Hello.
Yes, we do.
Yeah, yes, Rihab,
Yes.
Okay. So she had a lupus nephritis and renal failure due to lupus nephritis, and she had also past history of hypertension and a long history of lupus. Eventually ended with renal failure and needed a transplant after hemodialysis. She immediately after renal transplant, she got a delayed graft function. When there is delayed graft function, they usually rule out rejection and then investigate why this delayed graft function. Is it related to the donor or from the, is there any obstruction? So if you receive a biopsy early after transplant due to delayed graft function, look for causes of obstruction, ischemia related to donor, and acute tubular injury. And of course, rule out rejection. She recovered and discharged on prophylactic medication of immune suppression and anti-infection agents. So we discussed the past medical history here. She, after 3 months of this transplant, she got an episode of low-grade fever, nausea and vomiting, and generalized weakness of viral-like disease. On examination, she was okay, except of high temperature. Lab investigation showed anemia and thrombocytopenia and very high creatinine level with increased lactate dehydrogenase and low haptoglobin. So this lab picture is significant for some entity in the post-transplant or in kidney in general, kidney pathology. She had some proteinuria and blood and hematuria, but it's not that of the glomerular disease or specific glomerular disease. she had a fragmented RBC that will remind you of this entity. And they screen any transplant patient for viruses like BK virus and CMV virus, and she was positive. Combs test was negative, so no intravascular hemolysis. DSA, this is important to rule out antibody-mediated rejection, which was negative here. So she has no lupus activity, and complement gene studies, complement assays were negative. So this is also very important test to rule out primary thrombotic microangiopathies. The renal biopsy, you had a chance to look at that virtual slides. The first biopsy for this patient. It was a good biopsy with adequate tissue, including renal cortex and renal medulla. We see it's not a blue. If you see from the low power blue pictures, then you think about inflammation and interstitial inflammation, usually with rejection and infection. So it's not that blue, except for focal area of inflammation. Again, we can see here maybe ruptured tubules with protein insudation, protein material, calling the inflammatory cells to come and react around it. So if you are looking for rejection, you look for interstitial inflammation in non-atrophic area, tubulitis in non-atrophic tubules, but here mostly in atrophic area, the inflammation. The glomeruli has a pinkish material here. So residence, what do you think this material is? Is it hyaline? Is it fibrin? Is it anything else? Amyloid? Is it immunoglobulins, antibodies? Again, the same in each and every glomerulus, we have this material. And some endothelial cells have very enlarged nuclei, smudgy looking. Is it virus again, like the first case? Again, here we can see the this material, pinkish material, and is it sclerosis, glomerulosclerosis? It's not like RBC, because if you compare it to RBC, here are more red, the RBCs. It's pink, more pink and fragmented. By PS stain, sorry, I have my computer is about to restart, so I have another computer I can share with you. So can someone unmute me? I can't unmute myself. Hello?
Yes, Rehab?
Yeah, can someone unmute me, because the other computer will restart. So I switched to my laptop.
We are listening to you here.
Yeah, it will restart. So you will unhear my voice. Sorry for that, but
I have to mute you.
unmute me. Unmute me.
Okay,
I don't
because
want.
that I heard it. Okay, I can unmute you.
Oh, okay. All right. I unmuted myself.
Mm.
And on PS stain, we can see here on
We
the right
cannot
side,
hear you.
like again the same material but on different stain. It looks PS pale staining, and on the left picture, we can see here. Can anyone annotate for me a finding in the glomerular endothelial cells? Anyone can annotate for me? Because I can't use my mouse. I don't know why. When full screen is there, I can't use my mouse. Use annotation and point for me the finding on the left picture. In the left photo, there is a finding.
There is a nuclear inclusion.
You can annotate it using annotation on the bar.
You can highlight this on the screen with your mouse somehow. You can actually like highlight it.
How?
We're hearing you.
There is a nuclear inclusion, but how to?
Yes.
Yeah.
Perfect. You're close to that. Yes. There is a nuclear enlargement with a halo around the nuclear inclusion, right?
Yeah.
Everyone can see it?
Yes.
Yes, perfect.
This one. It's good.
Okay. Again, with trichrome stain, we can see the same finding inside the glomerular lumen is obliterated by something obstructing the lumen, capillary lumen, on both glomeruli. With silver stain, this material also in every glomerulus, with some mesangiolisis and microaneurysm on the left side. On the right side also we have some nuclear changes of the endothelial cells. Enlarged, spongy looking. So, what's your diagnosis? Can we share the pulse, please? Shifa, can you?
No, bulls are not here.
Biopsy number 1.
Okay. So I have to share the biopsy number 1?
Yes.
I don't think we can click, can we?
Let me try. Okay, multiple participants. We can do, I think. Yes, I can share my, yeah. Okay. So,
Thank you.
What happened?
okay, this is my.
Could you share the polls, Shifa?
No, I can't share the balls from my computer.
Yes, now.
Okay, yeah, because yesterday we make a test and I couldn't, but today, yeah.
Yes, 100% correct. Yes, so non-renal pathologists know a lot about renal allograft. See?
Wow, 100%.
100% correct.
So because everybody follows Shifa's suggestion. Yeah.
No, but I didn't answer the question.
Yeah, you explained the approach. That's why they follow your approach. Good. So
okay.
in the poll, please.
Yeah, perfect.
in the poll and share the results, please.
Okay.
Then stop.
And now?
Yes.
Okay.
Then immunohistochemistry highlighted scattered endothelial cells with nuclear positivity in this biopsy. EM shows on the right side, we can see, unfortunately, I can't point it. This is a capillary lumen, as you can see, and inside the capillary lumen, towards the endothelial cells, you can see subendothelial widening. And on the left hand, we can see these arrows showing the aggregate of platelets. So there is endothelial injury and platelet aggregation, and that material on the light microscopy was fibrin inside capillary loops, which is a characteristic of TMA. Again, we saw also in the endothelial cells, on the left side, we see arrows indicating, showing the same TRIs as TRIs of the first case. TRIs, or tubular reticular inclusions, indicates interferon activation in the viral infection and autoimmune diseases. On the right side, we can see inclusions, viral inclusions in the cytoplasm of the cells, of endothelial cells, and the peritubular capillaries. So the diagnosis was thrombotic microangiopathy with CMV infection. We usually give estimate of interstitial fibrosis and tubular atrophy. It was moderate in this case. So we can, the clinician can see how this renal allograft will be in functioning, and also vascular changes is very important thing to indicate it in the report. There was minimal staining of C4D, but if it is less than 10%, we consider it negative. So there is no antibody-mediated rejection, because antibody-mediated rejection is a differential diagnosis of TMA. So we ruled out TMA clinically by negative DSA and histologically by negative C4D, and no other inflammation, glomerulitis, PTCitis, no other features of antibody-mediated rejection. And immunohistochemistry for BK virus was negative, and for CMV was positive. What is TMA? Thrombotic microangiopathy is a histological term. So it's not a clinical diagnosis. It includes a heterogeneous group of diseases, and these diseases are treated according to the cause of this thrombotic microangiopathy. So histologically, we cannot differentiate the cause, except for if we rule out the most common causes, the infections, the other causes. But for primary TMAs, TMA or primary like TTP or HUS, atypical HUS, these syndromes should be investigated clinically. This entity due to abnormality in the vessels that cause thrombosis in the small vessels. And in regard to the cause, it's divided into
Sorry, is it just me, or is everybody seeing the slides already? I'm stuck in, I guess, the same.
Yeah, I think all of us. There's a problem with that.
Sorry?
With what?
You're seeing what?
I'm just seeing the same slide for a while.
Yeah.
Oh no,
Exactly.
I'm seeing the slide moving, so it must be your internet.
Oh, okay, now I see it. Yeah,
No,
it could be my connection then.
Yeah. No, some of us have the same problem.
Yeah.
Okay, thanks.
All right. Primary TMA syndromes like TTP due to deficiency in von Willebrand factor that cleaves protease, and when this deficiency happens, then the patient has thrombosis. A very common entity is Shiga toxin mediated HUS due to infection related. So the patient most of the time presented with a history of recent infection. Complement mediated, which is atypical HUS. And this when there is a deficiency or in ADAM TS13 or any mutation or genetic disorder, usually affect the complement pathways. So this genetic disease, you don't, I don't know if you imagine that 50 to 60% of primary HUS are hereditary related. So only 10% due to antibody mediated, like antibody to complement. Secondary causes, of course, when the clinician rule out the primary causes of TMA, then we can, he can or she can, the clinician, look for the other causes, secondary causes of TMA, like pregnancy, hypertension, systemic infection, like in our case, drug-induced malignancies and autoimmune disease like lupus. But in our patient, lupus was not active. So infection was the cause of TMA because the patient has a viremia and the renal manifestation of CMV. So in terms of involvement, organ involvement, it could be systemic TMA, or it could be limited to the kidney. And in renal recipient, it could be de novo or recurrent. And recurrence rate, many reports has different rate. So it's usually from 25 to 50% recurrence rate after transplant. And de novo, so the patients, transplant patients have a significant incidence of TMA, de novo TMA. So these, again, drug and infections, viral infections and antibodies, antiphospholipids and malignancy are considered triggers or causes of TMA. So CMV, as pathologists, we commonly see TMA in CMV, sorry, in different organs, in GI and lung, but in kidney, it's very rare to see it. So how it is transmitted? The CMV is usually from the donor, or could be transmitted through other ways. How it causes TMA, the CMV, either directly or indirectly. There is hypothesis that it goes and damages the endothelial cells. And as we see in the EM, we see endothelial injury, like endothelial swelling and subendothelial widening, and affect the pathway, complement pathway. Either classic pathway or alternative pathway. So regarding our patient, the patient was treated for CMV by IV ganciclovir for 1 week, and then treated for TMA by plasmapheresis and other approaches of TMA. And if you can see here, her serum creatinine was improved. But after 14 months of a stable course, following up the CMV level, following the creatinine, she developed again acute kidney injury. What's acute kidney injury? Acute kidney injury is increasing creatinine. So what are the causes of acute kidney injury in transplant patient? We have to rule out first the rejection. We have to investigate for infections, for obstruction, for drug, could be due to CNI or vascular disease and other causes. So this is the second biopsy, and you had a chance to look at the virtual slide for the second biopsy. From the low power, it looks blue, and this bluish appearance due to inflammation. So inflammation, almost 90% of the biopsy. Here, interstitial inflammation in atrophic and non-atrophic area, but we consider more in atrophic area and non-atrophic area. Nowadays in transplant, they even count the inflammation in atrophic area as chronic active inflammation, chronic active cellular-mediated rejection. We can see here many plasma cells. So plasma cells most commonly in viral infection, but it can also be seen in cellular rejection. Lymphoplasmatic cells. We see here in, if someone can annotate for us, tubulitis. There is severe tubulitis. If you choose a non-atrophic tubule, how do you know this is non-atrophic tubule? It has no thickened basement membrane, and you count a number of lymphocytes inside it. If in the cross section more than 5, so it's moderate. 3 to 4, it's mild tubulitis. More than 5, up to 10. If more than 10, it's severe tubulitis. So we have tubulitis. Again, tubulitis seen in infections and in rejection. Yes, thank you. Again, more tubulitis, more interstitial inflammation, and the cells has enlarged nuclei and prominent nucleoli. If you can appreciate it here from the low power, it shows reactive changes, which is sometimes more ugly than viral cytopathic changes. So the role of immunohistochemistry here is very important. Yes, some glomeruli shows inflammatory cells when these capillary lumens full of lymphocytes, we call it glomerulitis. Here on the left side, we see globally sclerosed glomeruli. So this cannot be considered as glomerulitis. We should see it on an intact glomerulus. Like here, segmental glomerulitis, mild glomerulitis. So glomerulitis is seen in antibody-mediated rejection. Again, the same findings with PS stain. But here, this tubulitis is in a medullary area. How do you know this is a medulla? Because of vasa recta. Again, more glomerulitis by silver stain. Nicely highlighted, tubulitis. And vascular changes. Like here, the pink nodules are hyaline nodules. C4D was positive, but weakly positive, around 10%. So we consider it positive, mildly positive. And because this case was lupus case, we should also include other immunoglobulins. By the way, we did the immunoglobulins and complements panel on the first biopsy was negative. And here again, it shows 1+ trace staining for immunoglobulins and complements. So no lupus recurrence. Again, if we can see what do you think the diagnosis. Can we share the pulse, please? Shifa, can we share the pulse, please?
Okay, Rehab, I'm just choosing the question. It's number
biopsy 2.
Okay, this one.
I also would like to remind that the residents had to attend to their half day since this is past 1, so we lost some attendance as of now.
All right, sorry.
So we need to wrap the talk as soon as possible.
Okay, we're about to finish. So yeah, I see 50% antibody-mediated rejection and 50% TMA. Can we end the polls, please? Yes, 50%. So antibody-mediated rejection is correct also because, but we see also T-cell mediated rejection. So the most severe is tubulitis. Severe tubulitis and severe interstitial inflammation, usually with T-cell mediated rejection. We see weak, very weak PTCitis and C4D positivity with mild glomerulitis. So maybe there is an element of antibody-mediated rejection. Stop sharing, please. Yes. Thank you. So this is the patient creatinine. It was in 400. The normal is up to 100. So it's elevated, and the time of after time of transplant, it dropped, and it came up in the event of CMV. And with treatment of CMV and TMA, it came to the baseline. And after 14 weeks, she developed a peak of creatinine due to this rejection, acute and cellular antibody-mediated rejection. And despite treatment, the patient couldn't went down to the baseline again. So she continues to stay on that level, and she lost her graft and went back to the dialysis, unfortunately. And she was still anemic, so they decided to remove her graft. Usually they don't remove a non-functional graft. They leave it there and they transplant again on top of that. But because she experienced severe anemia and they don't know how to explain it, they just did a graft nephrectomy and showed chronic changes, severe interstitial fibrosis, severe vascular changes that could be related to chronic TMA or could be related to transplant itself. So please join my poster to discuss the case more. It's near my office and I leave it here. In conclusion, if you find glomerular fibrins and viral cytopathic changes, so think about TMA that could be due to viral infection. And TMA, CMV very rare and even more rare in transplant, and should be with clinical pictures. So not only finding the fibrin, the patient should have a clinically manifestation of the TMA, like anemia, thrombocytopenia, high LDH, low haptoglobin, and rule out other causes like antibody-mediated rejection and infections. And thank you very much. I hope you can now approach the renal biopsy by ruling out the rejection and infections and obstructions and tubular injury. And thank you very much. Please let me express my gratitude to UHN-LMP because this is my last month in fellowship. I have enjoyed my 2 years fellowship with Dr. Avila Casado and the team, all the team. I learned a lot, and thank you very much. I will be next month inside the lab rotating, and because I'm excited to build up my own EM lab, so I have to know some techniques. But anyhow, you can come anytime to my poster in the residence room. And thank you very much.
Thank you. On behalf of the Education Committee, I would like to thank both speakers for their excellent instructive sessions. So if there are no burning questions, I would like to adjourn the meeting. Please don't forget to fill out your online evaluation, the attendance form that Nevita has spread it in the chat, if I'm not mistaken. So any burning questions or any comment from Carmen?
Thank you very much for your attendance, everyone.
If there are no questions and I don't see any raised hands.
I just want to thank everyone, and I want especially Rehab and Shifa that had the challenge to present in this new modality. Thank you very much for doing that. And you did a very good job with that, and really appreciate that. So we're doing great. Thank you.
Thank you very much.
Thank you so much for your support and giving us this opportunity to start the case-based round again. Thank you.
Thank you again. So if not, you can always find both Rahab and Shifa for additional discussions around the cases, and as well as Carmen as well as needed. So with this, I would like to thank everyone for the attendance. As I told you, like until up to 1 p.m., all the residents were here. We reached at some points 37 attendance. If I'm not mistaken, so Nevita might have captured the total number. So it is a great success, and I would like to see this is a continued part of our educational program. So thank you very much. Have a wonderful afternoon to everyone.
Okay, thank you.
Thank you, Nevita, as well.
Yeah, we have. You have the link of attendance?
Yeah, I do. I posted it. Apparently,
there was a glitch in the email part. Nevita, when I fill out mine and when I enter my email, it says enter a number. So this is why I typed my name and I left.
Already, from the beginning, I wrote everybody's names down on the paper. So we're okay.
We should improve that one. But again,
yeah, that happened to us. I also sent my name with my extension number because the email was not possible to add.
Yeah. So if you just put a random number, we mainly need your name more than your email.
Perfect.
So
Thank you. Thank you, everyone. Have a wonderful day.
Thank you.
Bye-bye.
Bye.
No, it's okay. Thank you. Thank you, Matilda.
Wonderful job, Rehab. Thank you.
Thank you for support.
No, thank you for your support. I'm in the office, so anytime.
Yeah, okay. Thank you. Bye.